the best way to help increase their actual cultural competency behaviors is going to be by providing as much experiential learning as you can. But as an educator, if you're not even aware fully yourself, you can't provide those experiences for your students. It's very important to understand that not everybody thinks and feels the same way as you do, and it's okay. It's just different. But as healthcare providers, it's absolutely 100% our responsibility to be aware of that. You can't know every nuance about every culture, but you need to be sensitive that there are differences and at least be aware and make an effort and know where the resources are. And that's the cultural behavior aspect. Have resources and use them and make that little bit of an effort, because it may make a big difference down the line.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 277. Everyone, this week we have an amazing episode. We're having another takeover of the podcast by the wonderful people over at Hygiene Edge. We're so thankful for our partnership with them. You guys are going to love what they're bringing for you. If you haven't caught on, every month they're giving a little something to our audience, whether it's a tip episode or in this case, a full-length episode. They are amazing clinicians. They're amazing educators. They have an amazing platform built to help everyone else. So please go check them out, support them, and thank you again to them for supporting us in our podcast efforts and bringing the knowledge to the people. Without further ado, here is Hygiene Edge. Before we get to the interview, we want to say a big thank you to Paradise Dental Technologies, or PDT, for supporting the continuing education portion of this podcast for so many years. If you do not know already, many of our full-length episodes count for CE. You'll find the links in the show notes, or you can sign up for our newsletter by going to ataleoftwohygienists.com. When you sign up for the newsletter, we will periodically send out links to shows that have expiring CE courses attached. And none of this could be possible without the support of the amazing people over at PDT. So check out their hygiene and other instruments at pdtdental.com. That's pdtdental.com. Now, on to the interview.
Hello. We here at Hygiene Edge are so excited to be back with you. This is Jessica Atkinson and Melia Lewis.
Hey.
And we are, hello. We want to talk to you today about minority health disparities. And before we get started, I just want to make mention of my super great radio voice. I did this just for you. I said, please let me have a cold so I sound super good during this interview. So here is my beautiful radio voice for you all. So if you're wondering if I'm dying, I'm not. This was all for the radio voice. And we would like to talk today about the minority health disparities. Did you know these quotes or tidbits of information are from the CDC? And among working age U.S. adults, over 40% of low-income and non-Hispanic Black adults have untreated tooth decay. Did you know that nearly 18% of all working age adults and 29% of those with lower incomes report that the appearance of their mouth and teeth affects their ability to interview for a job? Did you know that based on data from 2011 to 2016, for children aged 2 to 5 years old, about 33% of Mexican American and 28% of non-Hispanic Black children have had cavities in their primary teeth? That is compared with 18% of non-Hispanic white children. For children aged 12 to 19, nearly 70% of Mexican American children have had cavities in their permanent teeth, compared with 54% of non-Hispanic white children. Did you know that untreated cavities in racial or ethnic groups, nearly twice as many non-Hispanic or Black Mexican American adults have untreated cavities as non-Hispanic white adults? These are just a few of a long list of statistics that you can find at the Center of Disease Control These are studies that have been done that illustrate the disparities among our minority populations. And we here at Hygiene Edge have invited our resident expert and gratefully one of my dear colleagues that I get to work with on a daily basis to talk to you about cultural competency. What can we do as dental hygiene educators that will make a change, make a difference in the health of our minority populations? So I'd like to introduce to you Dr. Lisa Welch and tell you a little bit about her. Lisa Welch, Dr. Lisa Welch, I call her Lisa because we're friends, but she definitely deserves the title doctor for sure. Lisa has gotten her associate's degree in dental hygiene from Dixie State University, where she and I both teach now. She also has her Bachelor of Science honors in applied biology and biochemistry, Lancashire Polytechnic School in the UK. You are all going to love her accent. She has a master's degree in dental hygiene from Idaho State University and is a doctor. She has her doctorate in education for health professions from A.T. Still University of Health Sciences. And take a look in your April Journal of Dental Hygiene, volume 95, issue 2, and you will see an article written by Dr. Lisa Welch about cultural competence, the investigation of the cultural competence of dental hygienists practicing in a region of low diversity. So we've invited Dr. Lisa Welch here today to talk to us about what we can do to make a difference for our minority populations. Welcome, Lisa.
Thank you so much, Jessica. Thank you for giving me the opportunity to talk with you about this, because this is something I'm so passionate about. It's been the focus of my life, almost, the cultural competency in dental hygiene for about the past 4 years, in getting to the point of getting the research published and seeing what kind of a difference we can make. And absolutely, as educators, that's where we can. So
I love that. Tell me a little bit about what made you decide to go this direction for your doctorate degree.
It just kind of built on a number of factors. We all know about disparities in health. We know about disparities in minority populations. And the more I learned about it, the more it really made me sad. And I wondered what things we could do to change. There are so many things associated with the social determinants of health. Minority populations is just one of them. But if we understand our cultural differences, we understand how to communicate with cultures that are different than our own, we can serve them better and help with their oral health care needs. So what do we do to do that? And the first thing that I thought about was, okay, let's look at what things make a difference in cultural competency. And so some of the things that I learned as I was going through my doctorate, because cultural competency in healthcare as a whole is huge. And my doctorate was healthcare for health professions. So they had a large focus on teaching cultural competency to all different health professions. And you have to start by teaching the educators. So I learned a lot about that myself and some of the factors that make a difference. And one of the factors is diversity within the profession itself.
Yeah, we know about that.
Yep. And as hygienists, our profession is 85% white and 95% female. So we are trying to serve the whole of the U.S. population, which is a lot more diverse than our profession, with a population that doesn't have that diversity. So we just have to try and do the best we can and learn as much as we can about other people's backgrounds so we can associate and be empathetic and understand their challenges more. So in doing that, I looked at where we live, where I live, where you and I, well, all three of us live. In Utah, which has even less diversity, really, compared to other states. And the members of our profession in this state is even less diverse than the national average. I don't have my actual stats in front of me. Jessica might. I can pull it up. So,
See, I do. She did send me some stats, some of which I read earlier, and I'm actually scrolling through a few of those. And it's shocking to me, the disparity between the access to care or the treatment when people actually get diagnosed for these things, just between, as you said, our professional diversity is not so broad, and that of what we actually treat. For example, this statistic I'm reading right now is adults and periodontal disease. 42% of adults have some form of periodontal disease. And among adults age 65 and older, the rate of gum disease increases to 60%. With that, severe gum disease is most common among adults 65 and older, and Mexican American and non-Hispanic Black adults and people who smoke. So even our demographic, we are not very diverse. And then our ability to treat people in that demographic, we're not getting to the people who need us the most.
Absolutely. So when I decided to do my research, and if you want to pull the journal, if you guys are listening to this, you can pull the journal. You can look at the stats, not a plug there, but it really is. So my thought was, if we have a population of providers that has very low diversity, practicing in an area with very low diversity, let's see what their cultural competence is and where our gaps are. And so that might be a low baseline starting point to see where we're at. So, and I managed to find the stats. In Utah, I said, as a nation, we're 85% white practicing hygienists. In Utah, from the population I surveyed, it was 93% white. So just in that, and as a population, the demographic of Utah is a lot more white and predominantly Christian-based faith than a lot of other areas of the U.S. So not only do you have a practitioner population with low diversity, you also have not a lot of opportunity to practice, to learn about diversity, because you're not treating diverse patients. So I ran the research with a survey called the Cultural Competency Assessment, which tests lots of different aspects of cultural competency. And it is out of a score of 14. And 7 points of that score are for cultural awareness, and 7 points of that score are for cultural behaviors. So when we surveyed the participants of the hygienists here in Utah, we had, I believe, 661 full completed surveys returned that were included in the research. And it was actually quite encouraging, because the average score was about 10 out of 14, which really, considering the low diversity of practitioners and the low diversity of the population that we treat, that wasn't bad. But it was really unequally distributed. So there was a 6 out of 7 in cultural awareness and a 4 out of 7 in cultural behaviors. So we're aware of the differences, and we're aware that there are things culturally we should be doing, but we're not implementing the behaviors. So that was a big result of the research that we found, like here in Utah, that's what's going on with our practitioners here. Not surprisingly, those respondents that had graduate degrees scored a lot higher.
Fascinating.
Yeah, the high was 12 out of 14 for cultural competency in those.
And was that you? Did you take your own assessment?
No, I didn't. No, I didn't want to skew the results. That wasn't me. No, but
it was Melia. Melia, did you take her assessment? It was you.
So I don't know if we could pull that, because the results were separated from the respondent names. So it was completely blinded. Yeah. So.
Oh, maybe you should send it to us again to take, or send it to everybody.
I would be happy to, if you want to take it. Well, that goes along with future research that I'm really looking at doing, especially in education. But it was very interesting. Also, what wasn't surprising is hygienists that had practiced or were practicing in public health scored higher.
Really? Okay, that makes sense. I'd also be interested if recent grads score higher than those who have been practicing a long time or vice versa. I just know as a student, I saw a pretty diverse population as a student. And then I worked in 3 different offices, and depending on the office I was at, I had a particular demographic. And there was one office that I had quite a few different opportunities for exposure to different cultures. But man, there was one office that, I saw pretty much the same type of person 90% of the time. So that would be, so lots of opportunity for lots of research.
Interesting you asked that because time since graduation wasn't significant. How crazy is that?
Interesting.
Yeah, so it wasn't.
That's good. That's good. I'm happy about that. So what I'm hearing you say, Lisa, is we have on one hand a really high score on the awareness section, but on the implementation, we're scoring a lot lower. So how do we bridge that gap? Especially for dental hygiene educators, what can we do at that ground level where we're teaching the future of our profession? What can we do?
Okay, well, there's a couple of things, just very basic things that we can do. And again, in the research, what we found was the number of education hours that the participants reported that they'd had in cultural competency in school increased score. So that was significant. And the number of continuing education hours they'd had in cultural competency since graduation was significant. If that increased, it was significant. So it did show that the amount of education that the participants reported that they had did show significance, that it improved cultural competency. So as educators, we need to first educate ourselves. We absolutely need to take the steps. And there are some really great free resources available online. And one of those is the Think Cultural Health website that specifically provides continuing education in cultural competency for oral health providers. So that's the very first thing that as educators we can do.
Maybe we can get that link and we can have them put it in the show notes so you guys can reach to it. Yeah, that'd be awesome.
Absolutely.
Yeah. That's say that again for us, Lisa. Think oral health.
Think cultural health.
Think cultural health.
Yes, and it's for all healthcare providers. It's for nursing, it's for nurse practitioners, it's for PAs, it's for radiologists, but there is a specific section for oral health providers.
That's us.
That is. And there are 3 levels that you can take. So it's 6 hours of continuing education in total. There are 3 modules that oral health providers can take. Each one gives 2 hours of continuing education. So it's free, so you can take that. There's also a course that you can take to become a facilitator. So you can actually become an educator facilitator for providers. So not only could you use the information out of the Think Cultural Health website for your students, it can also be used for continuing ed for existing providers. So when we look at providers outside of education, something we can do is to encourage providers to go to this website and take a look and educate themselves.
So this would be for us as educators to a starting point. And the thought that I had with this is, I know in our particular program, we have senior projects, and I wonder if that could be an opportunity for students to become these providers and then teach in the community about cultural competency. So that's another avenue that we could get our students involved in the cultural competency, is provide this education for them as well.
Have you guys implemented other ways of cultural competency into your program or?
Well, one of the ways that cultural competency is increased is with experience. It's experiential learning. And it is difficult in Utah because it is just such a lacking in diversity. But community projects, as Jessica said, any kind of community outreach into diverse populations. We are looking at, we have a mobile clinic and possibly providing oral care to the Native American population. So actually taking our mobile clinic. So we've talked about that. But the best way to help increase their actual cultural competency behaviors is going to be by providing as much experiential learning as you can. But as an educator, if you're not even aware fully yourself, you can't provide those experiences for your students. But could the students take the Think Cultural Health website module courses? Absolutely. Yes, you could include them in your curriculum, whatever part of the curriculum that you have that you cover, public health or cultural diversity, those kind of things. Lessons and modules from the Think Cultural Health website can easily be incorporated into that. So,
what kind of didactic courses do you find that would be the easiest plug-in? Because I teach anatomy and embryology, and I'm thinking, I don't know if there's a module for cultural competency on anatomy and embryology, but I'm imagining maybe in like your theory courses, or there are a number of places, geriatric, pediatric. Every school has a little different application of code of requirements and which courses kind of envelop different topics. What do you think would be the best place to supplement or supplant? I think the word I want here is supplant more cultural competency, more on a didactic level in order for them to have that to implement into their clinic experiences.
To me, it naturally falls within public health, whatever the program has as its public health, because when you look at the national board, half of the national board is your tests on public health. So a lot of most schools' curriculum has a significant public health portion. So it would fall naturally in that, depending on the level of the hygiene program, whether it's an associate program, whether it's a bachelor's degree program, there are different areas. If it were a bachelor's program, there are the advanced courses, leadership courses, education courses, those kind of things that are included within a bachelor's curriculum. These kind of modules would naturally fall within that. But we do need to get it within our core dental hygiene curriculum. Like for associate educated hygienists, it is that important. It's not something that is then added on as extra courses in the bachelor's degree would be. If it were not included in those courses, some significant amount of cultural competency needs to be included core within associate's curriculum.
What could that look like in our clinic, Lisa? What could we do to really focus on cultural competency in clinic? I've had an experience in my education where I've had a student not want to appoint a patient because they don't speak the same language. I've had situations where there's that barrier that doesn't have to be there. So what would you think we could do as far as our clinic experiences to enhance their cultural competency?
That is a really good question that I don't have a perfect answer for, but I have maybe a suggestion. Just as you're asking that, I'm thinking. In our program, we have projects that the students have to do related to their clinical experiences. So they have to take their experience from the clinic and apply it into their didactic course and give presentations, and vice versa. They have to take their information from the didactic courses into the clinic. And 3 or 4 areas I'm specifically thinking about is we have our students do a project on a periodontal patient. And we have them do a project on a caries case study patient where they do a full risk assessment. So what I'm thinking is that have one of their requirements be an assignment that they have to present a project on overcoming a cultural barrier.
Well, according to these statistics, Lisa, when we do those projects, I know in my own experience as an educator, most of those people fall in the category of a minority. When they find these patients who haven't had the treatment for their periodontal disease, they become an opportunity for them to learn a lot on. And it also shows that these populations don't have the access to care that maybe the majority do. So I think that would be a really good idea for that type of a case study to add a cultural competency aspect to it. And was there anything they needed to be aware of or do in treating this particular patient? With these statistics, it's more likely that we're going to see somebody with severe periodontal disease that isn't a minority a minority population. So that would be a good idea.
Absolutely. And part of the assignment could be that they would have to research ways of being culturally sensitive to the population, but also what culturally congruent, that's another word, cultural congruent, is acting in a culturally competent way. What culturally congruent behaviors could they implement to better serve this patient?
And get better case acceptance, I think.
Absolutely. And it would be not a research project, but a project of learning where they would investigate the best ways to treat this patient and then give a presentation so they could all learn about each other's students and learn about different ways of implementing culturally competent behaviors. Because like we said, we're all culturally aware. We have high awareness, but what behaviors would they do differently?
Give us some examples of different behaviors there, Lisa. Between the three of us, we have experience in 4 different hygiene schools in the state of Utah. And I want to hear a little bit about what these behaviors would look like and kind of think about our past experiences to see what's worked for our students, because we are scoring pretty high on the competence, but the application is missing. So I kind of want to know what that would look like and maybe how we could improve that.
The first thing that everybody thinks about when they think, providing culturally competent care, that means that I have to get an interpreter. And the big sigh. Well, if the person doesn't speak the language properly, then yes, you do. But there are resources available for interpretation.
Yeah, not their child.
Yes, not their child. If you are interpreting in a medical situation, it needs to be a confidential situation and it needs to be interpreted properly. And using a child or a family member that is not fluent, very fluent, and isn't of age is not recommended at all. But there are programs. There is Google Translate. Yes, it takes longer, but it is important to try to provide as many resources as you can to provide as best communication as you can. So that is the first thing. So the other thing is having just materials, if possible, in the language of the person. So having educational materials, being aware of where you can find those materials. And one of the places is the Think Cultural Health website. The materials are there. The educational materials are there in different languages. You just have to make the effort to look for them and find them for your patients, rather than being, I know that it's going to be difficult because we don't speak the same language, so I'm just going to avoid trying to teach the patient anything. We'll just avoid patient education and I'll just clean their teeth and it'll be fine. Whereas if you make that extra step to try and communicate, try and find resources, have resources available in the clinic, have resources available in the doctor's office, in the practice once you graduate, that you can use. Subscribe to internet services so you know where they are. Have them bookmarked on your computer so you're like, okay, I know that I would like to teach this patient this, and I know where I can find a resource in their language. Possibly not even just a written resource, possibly a video resource. They're out there, they're available. Just making that extra little bit of an effort to find them, know where they're at, and have them available for patients if they need them. That's a huge thing.
So in my experience with Melia, she and I used to work at the same college, and we had a Spanish in a pinch book. I just remember this. And they had common phrases used in a dental office that were easy to understand and easy to say. There were little mnemonics in order for someone who doesn't have Spanish as their primary language to say something correctly, which was really helpful. Melia, do you have any other experiences in the colleges that or universities you've worked in that show opportunities for cultural competence?
Yeah, I was just thinking, like Elisa, I'm just loving all this, but I was just thinking about today. We had it happen today. And, in clinic, it happens every session, right? Clinic session, always something happens, something comes up
right.
this situation. And I think educating the instructors is so important because the students, especially in a clinic setting, they totally feed off our energy. And if we feel uncomfortable and the patient feels anxious, like the student's going to feel so anxious, and then there's not a great lot of learning, right? If there's so much anxiety. So today we had this cute little patient. She was from Chile and she spoke a little bit of English and I speak a little bit of Spanish. So, we tried to work it out. And she came in initially, they made like a treatment plan and did all the, make a diagnosis and stuff. And then today she came back for the treatment. Well, the student said that they explained local anesthesia, but there was a disconnect because she didn't realize local anesthesia meant a shot, which I totally get that, right? Like when like if you explain local anesthesia and you don't say shot, no one understands. So anyway, we lean her back and she was like, wait, you're giving me a shot. And she got really anxious, but we were able to chat with her and feel comfortable. But again, we didn't speak Spanish and she didn't speak English. Honestly, I totally put the blame on myself. I didn't explain it well enough that she might feel a zing or she might feel some numbing in the back of her throat if it drips or something like that. So we didn't communicate and the patient did feel really numb in the back of her throat because it kind of dripped. And she got really nervous and got lots of anxiety, like she had to sit up and she said she couldn't swallow and she was really nervous. And then the students started to feel super nervous and they had a lot of anxiety. But luckily for me, I've had this experience multiple times because it happens a lot. So I felt like I could be confident and just be like, try to diffuse the situation and find that way. But then if I'd never had that experience, if I was like a brand new teacher, I never had these culture experiences before, the whole appointment could have just gone haywire, like the patient could have left or not had treatment or just been super stressed the whole time. And she ended up being fine. But I mean, this happens all the time. And I was just like totally assessing myself. I'm like, I should have done this totally different. And I learned from it. But if I maybe would have taken these classes beforehand or, talked to Lisa beforehand, maybe I wouldn't have had this experience.
But that's what we want this experience to be, is for dental hygiene educators to recognize that they're in a pivotal position to change these experiences for themselves, the future of our profession, and the population we serve. And if we have the resources to improve our own cultural competency, my hope is that this will improve the health of our minority populations, which is tragically at a disadvantage. And we could talk forever about a lot of different contributors to that problem, but one thing we can do, one place we can take action is in our own realm, and that's in education. And so, Melia, even having that experience gives you an opportunity for next time having a different experience.
Right, totally. Which, I don't know, it might not have been a positive experience for the students. I don't know. So, but next time it will be.
You're absolutely right. One of the biggest barriers we're going to face in the US is a language barrier, and it is predominantly going to be Spanish speaking. I'm making a huge generalization, but that is going to be one big barrier that we will face. Implementing Spanish for healthcare providers is something that's been talked about a lot. That's something that I see happening. I really do see that happening down the road, that it will become an integral part of curriculum for most healthcare professions. So I do see that in dental hygiene. But we have to remember that problems with cultural barriers are not just language. A lot of the times they can be difference in religious beliefs, especially with people from Eastern religions, very different to what we experience here in the US. Barriers of trust and barriers of context. Something that's really important to remember as people being raised here in the United States. And when I first heard this, I was like, what? But the United States is a very low context culture. There's not a lot of context to our culture. We tell people what we want, and we are used to telling people what we want. And we, for the most part, compared to some other cultures, don't expect people to read our minds. We say what we want, and it's not considered rude or It's an accepted cultural norm to be able to speak your mind to some degree. In a lot of other cultures, it is not. You are expected, there's a certain level of decorum. The British culture and the American culture are different. And when I first came here, that was some things that I did have to get used to. The British culture is slightly higher context. And what I mean by that is every situation has a context to it. And it's socially recognized that you behave a certain way in this context. Now you get to a Eastern culture. If you go to Japan or China or those cultures, they are very high context cultures. There are expected standards of behavior in most situations, and they are very different standards of behavior to those here in the US. So you're expected to behave a certain way, and you're expected to be asked, how are you feeling? How are you doing? Not expected to tell someone. It's different. And so if you have a patient or even a student from a high context culture, and as a person from a low context culture like we are in the US, we may expect a patient to tell us if they're hurting, if they're in pain. From a high context culture, they will not want to tell you because they'll feel it's impolite or that it's not spoken about. They will want you to ask and inquire and be polite and it be teased out, if that makes sense. So it's very important to understand that not everybody thinks and feels the same way as you do, and it's okay. It's just different. But as healthcare providers, it's absolutely 100% our responsibility to be aware of that. And we have to educate ourselves, and we have to educate our students as providers moving forward. So you asked me some things that other behaviors we could do. And I spoke a little bit about, learning different languages, but we need to seek out the information on the other person's needs. So there are cultural assessments. We have a smoking questionnaire and we have a nutritional questionnaire. There are cultural assessments that you can give to patients that have questions like, I feel comfortable talking about this. This is what's going on. That they will answer questions in the cultural assessment that they would not be forthcoming to tell you. So having cultural assessments, that's something as educators we can start implementing in the clinic. Cultural assessments, so as we have an idea of possible cultural barriers we might face with that patient right off the bat and be able to address them, be like, oh, okay, we got that. The other thing is having the resource materials available. Like I said, having books available about different cultures. Not that you need to know everything off the top of your head, but that you need to know where you can find it. Google's amazing.
Yeah, we've got it at our fingertips. I don't think there's a time in the history of the world where we have had so much information so readily in order for us to really make an effort to be culturally competent.
Right. And so we need to have those resources available. We need to have them, like I said, bookmarked ahead of time. So we don't need to know everything about it, but we need to know where we can look it up quickly if we need to. I teach pharmacology. I told the students now, when I graduated hygiene school, there were only so many drugs. Now there are
like 2.
It wasn't that long ago. Yeah, close. But now there are
2 that I remembered. I'm like, this one is common for blood pressure and metformin. Got it.
Right. So it's important that you can't know every medication and you can't know all of the side effects, but you need to know if a patient's on a medication, you should be looking it up just to double check. So same thing with cultural competency. You can't speak every language. You can't know every nuance about every culture, but you need to be sensitive that there are differences and at least be aware and make an effort and know where the resources are. And that's the cultural behavior aspect. Have resources and use them and make that little bit of an effort because it may make a big difference down the line.
My suggestion to every hygiene student is you don't have to learn how to speak every language, but I would recommend you learn how to say 2 things in every language. Hello and goodbye, or how are you? And you just I can't tell you the connection that you can create with somebody, but just knowing a little bit of what they know, just a little bit. I mean, I picked up a little bit of Spanish. I picked up a little bit of Portuguese. I picked up a little bit of whatever, right? Whatever language, if you just know a little bit, it makes the biggest difference. If you can say thank you, or I was happy to be with you, you were happy to be with them, things like that make a huge difference.
You just absolutely hit the nail on the head. That is making that connection. That is making that effort to that other person, that you care enough to learn something about them. You cared enough to learn even a couple of words. That helps make that connection. That helps build the trust. So that would be a culturally competent behavior. It would be absolutely a starting point, better than even just communicating completely through Google. You can communicate through Google, but you could even try to pronounce it and look at the person. And, if you look like you're making an effort, it makes a world of difference. So, and that's, again, is the continuation to educate yourself and be open to it. And then ask people about their own explanations of how they feel about health and illness, because different cultures feel about health and illness very differently. And you, again, can't put your own expectations and your own experiences on someone else. If you've never had a toothache, you don't know what it feels like, and it's awful. Those kind of things. If you've always had a toothbrush, you don't know what it's like to not have one. If you've always had good oral health, you don't know what it's like to be very embarrassed about the situation of your oral health and not to want to talk about it.
Yeah, even what's appropriate to talk about. I watched a movie on an airplane once, had Aquafina in it, and it was about, oh my gosh, I wish I remember the name of it. But the culture was, they didn't tell the grandmother that she had cancer. They didn't tell her. She was diagnosed with cancer, but they didn't tell her. And that was an acceptable thing. And Aquafina, not Aquafina in the movie, but anyway, she was raised in America, and she was completely shocked that this would even be okay not to tell someone that they were diagnosed with something. But it was very cultural, and they didn't. So even like having those conversations with people, what they would find appropriate to disclose and not, and trying to navigate around that in order to give them the best care is tricky.
Oh, absolutely. And there are Eastern cultures where the culture is that the man is head of household 100%, and that is culturally acceptable. It is the way it is. And so if you have a husband and wife come into the office and you are addressing questions to the wife and she is looking at her husband and her husband answers, and you continue to address the questions to the wife, if you say something like, well, I would like you to answer, or that's actually not culturally appropriate. That's because that is our culture. Their culture is that it is respectful to have their husband answer for them. That is what they are comfortable with. And that's what we have to respect. It's not the way that we may have been raised. It's not something we may be accustomed to, but that is equally as rude as us going to their culture and them addressing our husband or father as women, and us wanting to speak to ourselves, for ourselves, and us speaking for ourselves, and them continuing to address our husband or father. So it's the exact same thing. So it's something to be aware of. And the cultural assessments can help with that. Just the same way, and cultural assessments don't just have to be about ethnicity. They are also about gender and all of
religion.
Those. Yes.
Yeah.
You know, so just asking in the cultural assessment, asking someone the pronoun they would like to be addressed by.
Right.
Those kind of things.
Yeah, that opens up a whole new avenue of cultural competency, is respecting what somebody wants to go by as far as pronoun. Yeah, okay. This is awesome. So what I'm hearing, Lisa, is we can start by becoming more educated ourselves as dental hygiene educators, start with the free resources, think cultural health, look for ways to implement that into our didactic courses. And then in our clinical courses, look maybe at a resource where we can have a cultural competency questionnaire for our patients, or even start by having a cultural competency questionnaire for our students. So those are ways to start. Another way to start is to practice just a few words in the languages that you see often. These are great practical things that we can start tomorrow in clinic. We have at our fingertips anything we need through the internet as far as being more culturally competent for our patients to increase the care of our minority population. Awesome. Thank you so much, Dr. Welch.
Thank you.
I can't wait to see what else you have in store as far as studies and research and all of those wonderful things.
Stay tuned, because we need to research what is working. So that's what we need to do, because part of the problem is we don't have really good educational materials. We don't have good educational practices because we don't know. So that really hasn't been investigated. So you ask me, what can we do? I can't give you literature to say this has been done and it works, because it's not out there. So
this is an invitation for all of you who wants to do some research.
For sure.
Well, we are so grateful that you took the time out of your day.
And just I just want to say thanks for putting all this time and effort into just making our career and our schools and everything just so much more educated in this area that we don't talk about that much. I feel like I don't know. It's definitely a need that we all need, even not just healthcare. Like everyone in the world just needs to have a little bit more cultural competency to our neighbors and our communities and our friends. So thank you.
Absolutely. Well, it is something I'm working with Dixie, with our teaching and learning department for faculty, because it's important in higher ed. So it isn't just important for dental hygiene education. It's important in higher ed to be able to relate to students and for their future careers as well. But for me, hygiene is my passion, and it just all the pieces fell into place, and it just was a need. Like you said, it was something that I realized that there was a gap in the knowledge. And I'm just super excited to see what we can do in hygiene to do better serve our patients. And we can. And we have amazing people in this profession. We really do. So it's not just me.
The truth.
There are a lot of people out there working really hard to help provide care for underserved populations. So this is just a small piece of it.
It's an important piece, and we're grateful for the work that you've done. And stay tuned.
Yeah.
Thank you so much, Dr. Welch.
Okay, thank you.
Well, another great week, another great episode. We thank you all so much for listening each week. If you haven't already, hit that subscribe button, whatever podcasting app you're using. Also, just a reminder, our guests are so fantastic that they love when you reach out. They love when you interact with them on social media. And you can interact with us on social media as well at Instagram or Facebook. We're also on LinkedIn. You can find us at A Tale of Two Hygienists. You can also go to our website at taleoftwohygienists.com. And we would love for you to go there and subscribe for our newsletter. We have lots of stuff on our website. We have a learning center. You can search for any episode. This is an easy place for you to find the links for our CE courses and take the test. There's just so much more there. So head over to ataleoftwohygienists.com. And if you want, you can also send us an email. I'm Michelle at ataleoftwohygienists.com. And then there's Andrew, who is Andrew at ataleoftwohygienists.com. And we just want to say thank you so much. If you love this episode and you're loving the podcast, we would love for you to subscribe and leave us a review. And, 5-star, go ahead and do it. 5-star, just hit that 5-star and then leave us a review. We really appreciate it. We love reading them. It fuels our fire, and we just appreciate you guys so much. I think that's it, Andrew. Anything else?
Nope, that's it. Have a good week, everybody.
Bye, y'all.